This is KNWA Today in high definition.
All new this morning, Arkansas ranks #1 in the nation for the most trauma fatalities, surprising to some. But now a trauma system in place in the natural state is working to shrink those numbers.
It's called TraumaComm, and the system is the first of its kind in the country. It's designed to get the right patients to the right place at the right time.
Now, what used to take patients 6 to 8 hours to find the right hospital and doctor, TraumaComm cuts that down significantly to just 7 minutes.
He was so cute. Hey, Morgan, you need to get on that side because my back door's broke. Let's put our stuff in the back. Let me pop the trunk.
These Christmas presents.
I'm so excited. They're going to love it. Oh my goodness, guys, my legs are so tired.
I know, I was shocked till I dropped. Oh my
Did you have fun?
Yeah.
Was Ashlyn there?
Yeah.
Yeah. What'd y'all do?
We danced.
Danced. What else did y'all do? You gotta help me make Austin cookies tonight, okay? Can you do that?
Yeah. I want to get on the back.
Back right. Okay. Oh, you're getting way too heavy for mommy to take care of you like this. What kind of light bulbs are y'all wearing?
Our bottles are full. We're good to go. Med 3, how's everything look today? We checked off, good to go?
Everything's checked off, clean, we're good to go.
Okay, what about E3?
We're good to go, Chief.
Okay, SCBA's been checked.
Yes, ma'am.
Hey guys, we should go to the movies tonight.
Yes,
That'd be
let's
fun,
go.
wouldn't it?
Do you want to invite Kayla?
Yeah, text her right quick.
Okay, let me text.
Hey, let's take a picture for Instagram.
Okay. Jordan!
The trauma system obviously has made vast improvements in EMS and patient care in the state. I mean, you look back 25 plus years ago, we would have patients that would sit in emergency departments for 5 and 6 hours.
Prior to 2009, when the trauma system came into existence, what would happen, the ambulance would have shown up and the paramedics and EMTs that were manning that particular ambulance would have taken you to the local hospital. No matter the capability and capacity of that hospital to treat your specific injuries, you could have had injuries that they could not treat. They'd be too serious and the hospital couldn't handle it.
You know, when I first started flying, it wasn't uncommon for the med crew to get to a hospital and have to wait just because we didn't have an accepting physician for the patient. So now most of the time that's taken care of by the time we get there. So all we have to do is assess the patient, get the patient ready for air transport, and then go to that center that's accepted the patient.
There was never an option to take a patient anywhere other than your local hospital. In the field side, you would take a patient to the local hospital knowing that that's not where that patient needed to be. And you knew if it was your family, that's certainly not where you wanted to go, that they needed to be somewhere else that had the capability to take care of your family or your patient.
We're talking about saving lives. And here again, to save lives, you have to get them to the appropriate facility. And with that, with the new trauma system, that's what we're doing.
Attention, Station 1, Engine 3, Medic 1. Two-vehicle accident in the area of 105, Highway 10 with possible entrapment.
Dispatch Medic 3, show us en route.
Once the pagers go off and the tones go off, we start thinking about where is this at? What route are we going to take? Are we going through a school zone? Do we need to avoid a school zone? What are going to be those hidden dangers that we're seeing when we're en route? Is the train going to be crossing a track at a specific point? Do we need to take somewhere else?
Get out of the truck, you get out of your vehicle and you're moving toward the scene of a crash. So you see a car, it's on the highway, you can make an assumption immediately that the crash was at highway speed. So already, as I'm walking out of my vehicle toward the car and the people that I'm going to support, I know I'm calling the call center, this is at least a moderate patient. Now my assessment is of the patient themselves. So then, if they meet certain physiologic criteria, if they really have derangements of their mental status, their GCS, derangements of their respiratory status, tachypnea, or not breathing enough, or not breathing well, or not moving air well, that puts them in a category, or hemodynamic instability, blood pressure's too low, heart rate's too high. Now I've got physiologic criteria that move me from that original moderate category up to a major category.
Again, the field triage guidelines, the new trauma triage guidelines that the state has set forth within the trauma system are very important for the first responders to understand, as that can make a determination, number one, where we can decide and find out what hospital we need to start going to before EMS arrives. We can talk to them and tell them, hey, we've checked into the trauma triage, we figured out that this service is open or that service is open. Upon arrival of the scene, we're scanning the scene. We're looking to see, number one, how bad of an accident is it? Is there any dangers? Do we have power lines down? Do we have gasoline? I mean, there's just all these things that are running through your mind. Where do I need to position my engine or my rescue truck? Do I need additional resources? In this particular incident, we had an engine. Do you need a specialized rescue unit to come out because of the damages to the vehicle? Next thing we want to do is make an extrication judgment or evaluation. Who do we need to get out? When do we need to get out? We need to put people inside the vehicle so they can be with those people and let them understand what's going on, because that's a lot of noise coming in. You have sirens, you have motors, you have people hammering with axes, etc. This is pretty scary to a person that's inside a vehicle that has never been through this training. Keeping up vehicle extrication skills and standards is very important when it comes to the fire side or the rescue side when we're talking jaws of life. Getting people out of vehicles, getting people out of machinery. There's several different ways of getting people out, and we're continually learning different ways. Rescue is just like emergency medical services. We learn things differently. And as equipment changes, as cars change, so do the crumple zones, the safety factors of the vehicles, all the way down to the metals of the vehicles. You have to cut things differently. When you're talking school buses, jaws of life don't work very well. So training is a must. You can get training again all over the place. Arkansas Fire Academy has some vehicle extrication training. You can do it in-house if you have sets of jaws. A lot of these record services will come along and donate vehicles that they know they aren't going to use, and they'll bring them to you, you cut them up, and they take them away. It's a tax write-off for them. Learn your different vehicles. Don't get the same vehicles each time. Get pickup trucks one time, get a car the next, get a van the next, because again, not any one single piece of equipment will work on every single vehicle and every single technique. So you have to learn different techniques on different vehicles in different situations. So we put people inside of those vehicles, and at times this may also be putting in a paramedic inside the vehicle to start IVs and start medications with those life-saving medications that will end up keeping the patient alive while we're extricating. We need to be looking at different ways when we're extricating. When we do an extrication, we have a rule in our department. We have 3 different ideas of how to extricate. A, B, and C. If A doesn't work, we go to B, but then we come up with a D. So we always have a backup plan if something doesn't work. All extrications are different. We have to learn what different departments or what different vehicles, different cars, and how to do those things with the different types of vehicles that we have on the road today.
As Air Medical, we want to be a resource to that ground crew. They've started from square one. They've offered the life-saving. They've ruled out the life threats, hopefully corrected those. They're the ones that deserve the credit. We're simply here as a support, as well as TraumaComm being a support to help get that patient to definitive care. But that's where all the credit needs to go. After they've done what they need to do and we can help, we are more than glad to do that. And we want to work with the ground crew. One of the most important things is their report to us as to what went on. A lot of times we don't get to see the scene. We go by what they tell us happened, mechanisms of injury, how that patient has progressed under their care. Have they deteriorated neurologically, hemodynamically? How are they doing from when the EMS crew got there? So that EMT, that paramedic that's on scene, those are your most important people at that point to help start getting those decisions made as to do we need air and where does this patient need to go, and then with the conjunction with TraumaComm, we get that patient to where their definitive care needs to be as quickly as possible.
Helicopters are in the picture, I think, at EMS for the speed, for the time critical patients that need to get to major trauma centers. You know, we do a lot with strokes and heart attacks and that sort of thing. And of course the trauma. The trauma is sometimes that's very time critical.
You know, we don't stay and play, we load and go. Anything that we can do on the ground, we can do in the aircraft, and that includes airway management. So if the patient is maintaining their own airway, but we suspect that, you know, we may need to go ahead and intubate that patient, we would rather be off scene on the way to where that patient is going to receive definitive care. And of course we can do rapid sequence intubation should we need to do that. And we can go ahead and maintain that airway and manage it well in air. So we try to spend at least amount of time on scene as possible after we do a thorough assessment of that patient, and then try to get them to where they need to go as quickly as possible. A few months back, we had a major flooding in our area of Arkansas, and their ground units could not get to certain places. So we received a call from the EMS in that area and asked if we would serve as their first responders until the roads got opened up and they could actually get their ambulances, to those areas. So one nice thing about helicopters, we can land in a lot of places. So it's great to offer that resource when it's needed, to the people of Arkansas. So if an ambulance can't get to you, there's a lot of times where helicopters can.
The right ankle as well. Are the fractures open or closed? Are distal SMCs intact in that extremity?
I think the Arkansas TraumaComm Center is probably one of the biggest assets to the pre-hospital provider if used appropriately. And I think a lot of times the call center's viewed in a negative manner because it's just not understood. I think for the medic in the field to have the ability to have access to knowing where the patient can get the best care at that time.
The first report is typically the TraumaComm of the patient reports, and TraumaComm doesn't need a full report. We just really need to know the ambulance service name, number, and where they're based out of, the patient's age and gender, vital signs, GCS, if there's airway compromise, external hemorrhage.
Air unit number 3, Arkansas TraumaComm.
Arkansas TraumaComm, go ahead. Air unit number 3.
Hey, good morning, TraumaComm. We're about just shy of an hour out from the Little Rock area in Conway County. We are lifting off from a motor vehicle accident, 2-vehicle head-on collision.
The paramedics understanding the field's triage decision scheme, you can kind of start at the top, and once you hit that first, this is it, then that defines what that patient is as major or moderate.
Lower femur fractures, GCS of 3, vital signs 106/74, pulse rate 92. We have her intubated. We've got a trauma band of A773421, Alpha 773421. Currently, we're going to be transporting towards the Little Rock area, asking for your recommendation for hospital.
10-4 Unit 3, copy mid-30-year-old female, unrestrained driver, partial ejection, has a GCS of 3, patient was intubated on scene, has bilateral femur fractures. Level 1 trauma center is going to be your appropriate facility in the Little Rock area. Copy trauma band 773421.
I think the major advantage of integrating the Arkansas field triage criteria in with the call center part of our system is because, again, we're then on the same, speaking the same language. We have a common language, so I know that a major or moderate patient anywhere in the state means the same thing to the medic on the street or to the call taker at the call center. And so it cuts down on the ambiguity, it cuts down on the time that it takes for that call taker to get us directed to the right place. So improves efficiency in our communication, decreases time.
We don't need the treatment that you've performed, really treatment that you can't perform. I can't intubate the patient, I can't control hemorrhaging. Things that would help us make a recommendation to guide you to the closest hospital versus bypassing hospitals. So it's a pretty abbreviated report. When it comes to the neurotrauma go by, we may ask you some questions about length of loss of consciousness, mechanism, blood pressure, and airway.
Hey, this is Patrick with TraumaComm. So I'll give you all a heads up. Life Flight 3's inbound to your facility, mid-30-year-old female. unrestrained driver, partial ejection, does have a positive closed head injury, airway compromise. She was intubated on scene.
We notify the hospitals for all major patients, so we can do that second report for you if you need be.
Patient does have bilateral femur fracture. They have about a 35-minute ETA to your facility. Thanks, bye.
Just let us know. We'll let them know on all majors, but if you tell us we don't have time to make that second report, we will make it for you on all cases.
With multiple helicopters in the state and helicopters flying, you know, to and from destinations. And then when we're coming back home, we're unloaded. We have the capability of picking up a patient on the way back home should we need to. We have the supplies and the resources to do that. I think one of the nice things about Fleet Eyes will be that, you know, TraumaComm will have a tracking mechanism as to where each aircraft in the state is. So if a helicopter has dropped their patient off at a specific hospital and is going back home, you know, we never know where trauma is going to happen. There may be a trauma that's within miles of a helicopter that's unloaded that can be there within minutes to that trauma patient. Fleet Eyes is going to give TraumaComm the ability to locate all the helicopters, to locate the nearest helicopter, be it for a trauma scene or be it from a sending facility that's needing rapid transport for a trauma patient that they have in their ER.
I think the Arkansas TraumaComm Center is probably one of the biggest assets to the pre-hospital provider if used appropriately. And I think a lot of times the call center's viewed in a negative manner because it's just not understood. I think for the medic in the field to have the ability to have access to knowing where the patient can get the best care at that time. You know, in the past, we would just take the patient to a hospital. We didn't know whether that hospital had the capability to take care of that patient, whether they had the surgeon that could operate on that patient, whether they had the staff that could care for that patient, or even the specialty to take care for that patient. And that wasn't even really a consideration for the field medic. And now you have the ability to make a radio contact with the call center who can give you minute by minute updates on what hospital can take care of your patient the fastest and the most appropriate, that has that level of capability to care for that patient. We didn't have that in the past. The other one is to really decrease the communications with the hospital. The call center having the ability that if I've got a major trauma patient, I can tell the call center I've got a major trauma patient. Where should I go? And they can give me that information and then make contact with that hospital prior to me getting there and activating that trauma team. That when I roll through the door, I know that patient's going to be taken care of right then like they need to be. Where in the past you would roll through the door and it would take an hour or even longer for that trauma team sometimes to even get, if they had one, to come in being on call. And so now having that capability to use the call center for recognizing that low destination that I had no idea that could take care of my patient in the past, and having that capability now is really invaluable to the field medic if they use it appropriately. Now I think a lot of times we call into the call center minor patients, that we think that we have to call everything into the call center. And the call center is not designed for that. It's designed strictly to maintain communications with the field medic for those major and moderate patients that we know that can't be taken care of like they need to be at our local hospitals, that they need to be moved to a more tertiary facility and they can expedite that transfer of care for us.
So in our trauma system, we now, for our second year, have two types of inter-facility transfers: urgent trauma transfers and non-urgent trauma transfers. And the difference is the response time for EMS.
(10-4) room assignment on arrival. Brian, you're going to be getting an 18-year-old female coming to room 10 from an MVC.
Hello, I'm the ER doctor.
We've got the CT report back and you have a laceration of your spleen. We're going to have to send you to a higher level hospital with a general surgeon on call. Is that okay? I'll start making some phone calls for you now.
Hi, I have a 18-year-old female who's been involved in a motor vehicle accident this evening.
Dr. Smith, did your patient come in EMS or POV?
When the facility contacts TraumaComm, we gather some information, get them in touch with the tertiary care facility, and reports given, acceptance is deemed, and that's really it.
Trauma band is 773-194. She was involved in an MVA. She's got a lacerated spleen. All vitals are stable, GCS is 15, and the images have been uploaded to the trauma image repository.
The sending hospital then calls their local EMS and advises them that they have a trauma transfer, and they have an agreed upon time to arrive. Now, for the non-urgents, hospitals cannot require EMS to be there in any less than an hour. They can still agree that we'll be there in 5 minutes, and that's 5 minutes is great. But if EMS says our system is busy, we have other trucks out of the service, we can be there in an hour, when they agree upon that, then that's absolutely fine and within the rules and regulations.
Today, with every service having to have 2 backfill agreements with adjoining counties, to ensure that the people within that county, should they get busy or overwhelmed, doing their day-to-day operational needs of their patients or the citizens of their county. If there's a patient within a hospital that needs to be urgently transferred and they don't have the resources or the capabilities to make that transfer, that they have the ability to call their neighbor, to call their EMS service in the adjoining county and say, can you help us out? And knowing that that agreement is written, that it's there, and that we agree to help each other out in those instances, I think has also decreased the time for these patients sitting in the ER for extended periods of time.
TraumaComm, this is in regards to the patient we reported a while ago. We were en route to the level 3, bypassing our local hospital. However, our patient has near lost vital signs. She's a GCS of 3 now. We're unable to intubate. She's clenched. We cannot RSI. She's becoming hypotensive. Can you recommend a closest hospital for us?
10-4, since a decrease in vital signs and GCS 3, unable to intubate, TraumaComm recommend you go to your closest level 4 facility due to airway.
10-4, copy the local level 4. If you'll let them know we're coming, we're about 7 minutes out, and give her unable to provide a report if you can give that to me for us.
The EMS is very vital to our trauma team activation. We rely on their report to activate it early prior to their arrival so that the trauma team's prepared. So I've discussed with our EMS what our trauma activation criteria is composed of, why it's very important to get a Glasgow Coma scale. Initially, it would just say altered mental status. Well, altered mental status can mean a lot of things, whereas now that I've worked with EMS and they know that for a level 4 facility, a GCS of 12 meets our trauma activation criteria. So now EMS pretty much always gives us a GCS. I've explained to them that the blood pressure is another criteria for our trauma activation. If it's 90 or less, it meets our trauma activation criteria, along with a mechanism, a traumatic mechanism. The respiratory rate or assistance is another criteria for our trauma activation team. So once I explain that to EMS, they don't have any problems. They give us that report that we need that's going to get our team ready.
Having a good working relationship with EMS is paramount at this point in time. They're actually the driving force behind all the major programs we have, including the trauma program. And if they don't get it right on the front end, it just typically tends to roll badly downhill. So it's important to get with them, PI their processes, and just have good open communication so that we can discuss what's better for the patient.
I can't imagine the stress in the back of that truck trying to get a sick patient to the hospital. But that time to pick up the phone and call and give a complete and accurate brief report to the hospital is so critical, because no matter where we are in the hospital, that 5 more minutes means 5 more minutes that my team in the hospital have to gather themselves, gather equipment, talk about a plan, and be ready. I think if I'm the pre-hospital provider, I think I deserve, with a patient who's sick, to have a team meet me at the door well prepared and ready to go. The more pre-hospital notification we get, the more likely that that's going to happen, and the more I think that the pre-hospital provider should expect that that's going to happen. If you can call in a timely manner a good, concise pre-hospital report, I think you should expect that you come in the doors of the ER and you're met with an appropriate trauma team response or a trauma activation.
She's already got a positive FAST exam, so we need to go ahead and notify ATCC and do an urgent transfer. So call EMS as well and make sure that they have a truck ready for us.
Now, do you want to do a CT prior to her leaving?
No, I do not want to do a CT prior to her leaving. No matter what the internal bleeding's from, we don't have a surgeon here, so we need to get her on down to where they can do some damage control surgery first of all.
Okay, I'll notify EMS.
A good example of a rapid transfer for our facility actually happened a few weeks ago. A motor vehicle crash. EMS brought the patient here because initially they couldn't get an airway for a GCS of 8. Once the patient was on the bed, patient's airway was secured, which just that alone, with probably the head injury, met the criteria for a rapid transfer. However, our ED physician, they utilize our fast ultrasound for fast exam and immediately saw that there was blood in the belly, and that was criteria enough to call ATCC. No CT scans were needed at all, and we actually got that patient out in 47 minutes.
One of the big differences between now in the trauma system versus 5 to 10 years ago is the fact that it was almost required that you had a CT before you send the patient. Now, even the people that we transfer to at the level 1 and level 2 centers realize if we've got criteria based on fast ultrasound that the patient goes ahead and gets shipped. We don't waste time on getting a CT when there's nothing that we can do about the result here. And so that's expedited the patient care even more.
Yeah, so we got her packaged up. EMS is here and we'll be sending her. She should be there in about 40 minutes. We also noted that she had a positive FAST exam and also did a chest x-ray and pelvis, which we're sending by the TIR, and then we're going to fax the rest of the information. It should be shortly coming there, so you'll have it before she gets there.
When I first took this position, I realized that a lot of the care we gave was because starting from EMS to physician to nurses and other personnel, that they weren't educated on trauma care. Education at our facility has made a huge difference. No matter how much I can put out the education and continue to tell them and continue to identify opportunities for improvement, they're just not going to get that true trauma picture until they have that outside education.
Our scene times are being cut down. Again, they're training with the different agencies involved to get those patients out of cars quickly or out of accidents quickly. Each individual department may not understand that, but most of these industries have a response team that understands how to get those patients out. So our emergency medical services need to go ahead and train with these people and understand what that industry in their area has.
Education is going to have to be you have to stay on top of it. I don't think you can get enough education as far as in the trauma system is concerned.
The Governor's Trauma Advisory Council, or TAC, provides leadership to the Trauma Advisory Council and its 6 subcommittees: Finance, Hospital Designation, Quality Improvement and Trauma Regional Advisory Councils, or TRACs, EMS, Injury Prevention, and Rehabilitation. The TAC meets on a monthly basis and furnishes valuable guidance to ADH on development of the trauma system. This statutorily mandated 26-member committee of experts is invaluable to the success of the system. The Finance Subcommittee is primarily responsible for recommending an annual budget each year to the ADH and ultimately the Board of Health for approval. In addition, the subcommittee reviews and recommends action on new funding requests not reflected in the annual budget. The Hospital Designation Subcommittee reviews site visit findings and provides the ADH with recommendations regarding designation, reviews letters of intent from hospitals that have not been designated, and is currently working on substantial revisions of the Arkansas rules and regulations for trauma systems. The Quality Improvement Tracks Subcommittee is responsible for the state-level performance improvement review of cases submitted from the tracks with opportunities for improvement. In addition, this subcommittee is responsible for review of state-level performance improvement measures and submitting recommendations for trauma system improvement to the TAC. The EMS subcommittee meets regularly to identify changes in pre-hospital business practices needed to implement the trauma system. Issues include implementing a statewide communication system, EMS data submission, and securing backfill agreements for EMS providers. The TAC EMS subcommittee coordinates closely with the Governor's EMS Advisory Council. The Injury Prevention Subcommittee provides guidance to the ADH regarding implementation of the statewide injury prevention program designed to reduce the burden of injury mortality and morbidity. The subcommittee reviews injury trend data over time to identify priorities for prevention activities and to monitor progress in injury prevention. The Rehabilitation Subcommittee ensures that Arkansans who sustain traumatic disabling injuries have access to high-quality, comprehensive rehabilitation in our state. The Rehabilitation Subcommittee has 4 goals: to ensure Arkansans who sustain traumatic disabling injuries have access to high-quality, comprehensive rehabilitation in our state, to create a systematic approach to capture acute rehabilitation and community data metrics to determine areas of improvement in trauma patient outcomes, to build the capacities of healthcare providers to deliver quality rehabilitative care, and to increase individuals' options to integrate successfully into the community. The 7 Trauma Regional Advisory Councils, or TRACs, like the Governor's Trauma Advisory Council and its 6 subcommittees, play a crucial role in Arkansas's trauma system. Whereas the TAC is the umbrella organization that provides advice and guidance to the ADH with respect to trauma system implementation, the TRACs bring together a wide range of healthcare professionals at the regional level to deal with issues that are important to their respective geographical areas. In short, this is where the rubber meets the road. Each TRAC has structured membership, bylaws, and meetings that are posted well in advance so both members and interested parties from the general public can attend. One of the principal goals of the Arkansas trauma system is to save lives and decrease preventable morbidity by getting the right patient to the right place as quickly and safely as possible. This means identifying the most critically injured patients and directing them to comprehensive facilities when practical. When at times critically injured patients present to a level 4 or 3 facility, the system is in place to facilitate rapid transport after initial stabilization. The system's secondary goal is to protect the resources of the comprehensive centers by directing less severely injured patients to the local community trauma centers, which can successfully treat them. Level 1 comprehensive trauma centers have 24/7 coverage with general surgeons, neurosurgeons, orthopedic surgeons, and numerous other medical and surgical specialists trained and experienced in the care of critically injured patients. Specialized trauma care, such as intensive care monitoring, treatment of vascular, thoracic, hand, spine, and burn injuries, is present in some comprehensive centers in the system. Level 1 centers also are required to have in-house surgeons, to train physicians and nurses in the treatment of trauma victims, and to perform trauma-related research. They are required to have general surgery residence programs and are equipped for community outreach and injury prevention programs. Level 2 comprehensive trauma centers, like Level 1 centers, also have 24/7 coverage with numerous medical and surgical specialists trained and experienced in the care of critically injured patients. The difference between Level 2 and Level 1 is that Level 2 centers are not required to have in-house surgeons to train medical staff in the treatment of trauma patients or to perform trauma-related research. A Level 3 facility has consistent general surgical coverage and 24/7 operative capability. These facilities ideally have consistent orthopedic coverage, and some have occasional neurosurgical coverage. The majority of patients presenting to these community trauma centers can be safely cared for in the center and do not require transfer. The Level 3 center, however, has the process in place to stabilize and transfer the most severely injured patients to tertiary facilities. A Level 4 trauma center exists in a small community hospital, where the expectation is that the trauma providers are knowledgeable in the initial evaluation, stabilization, and rapid transfer of critically injured patients to higher levels of care. Minor injuries can be cared for in these facilities that typically do not have general surgical, neurosurgical, or orthopedic coverage on a consistent basis. The Arkansas Trauma Registry, or ATR, is an essential component of our statewide trauma system. It is the standardized data collection system for data elements that describe the injury event, demographics, pre-hospital information, diagnosis, care, and outcomes of injured patients in all Arkansas trauma centers. It's also a source of data for research, needs assessments, and epidemiological and injury prevention activities. Rehabilitation is a vital part of any trauma system, and restoration of a patient having suffered traumatic injuries to normal function is an important system goal. Planning for patient rehabilitation begins immediately following arrival at the hospital. Rehabilitative efforts often begin during the hospital stay, and if needed, carry through to the patient's convalescence at a rehabilitation facility and even after reentry into the community. The Trauma Image Repository, or TIR, is a partnership between the ADH, the Arkansas Trauma Communication Center, and the UAMS Center for Distance Health. The TIR has expanded the existing ARSaves telestroke network and created a portal through which images can be sent from the first receiving hospital to the TIR. The repository would then convert the image data into a universal format and make the information available to the tertiary receiving facility to upload into their system. This allows the specialist in the receiving hospital to view the films and begin to make clinical decisions and organize the care team far ahead of the patient's arrival. Thus, a patient can now be moved directly to the operating room of the treating facility. Arkansas patients suffer from burn injuries at a higher rate than the national norms. The death rates for burns in the state far exceed the national average. Injury prevention, outreach, and education are the primary tools used to combat this issue. Burn education and the increased use of smoke detectors in homes have also proved to decrease this burden. Once burned, however, there is only one center in the state dedicated to the care of adult and pediatric patients with serious burn injuries. The Burn Center at Arkansas Children's Hospital has more than 450 admissions annually and sees numerous other patients on an outpatient basis. The care is extraordinarily complex. In a state heavily dependent on agriculture and manufacturing, Arkansas has a significant number of patients with serious hand injuries. Most hand injuries can and should be managed by the orthopedic surgeons in the community hospitals of Arkansas. Occasionally, the patient's injuries are such that a specialist in hand care is needed for consultation or immediate assistance with treatment. The ATCC is organizing a group of hand surgeons who've agreed to serve in a virtual call group, evaluating injuries through use of telemedicine and assisting the ATCC with an appropriate triage plan. The goal of the program is to get patients with urgent needs to a facility capable of providing appropriate care in a timely manner. Conversely, the secondary goal is to provide reliable referral and follow-up for patients with less urgent needs to decrease the burden of urgent transfers that our system now faces.
One of the things that's been so valuable in our system is the opportunity to do almost real-time quality improvement. And that comes under a lot of different monikers: quality improvement, process improvement, performance improvement, morbidity and mortality in the traditional sense. But what we aim to do with that is to take real issues that are coming up in the state of Arkansas and try to address them, not in a punitive way, but with an eye toward opportunities for improvement. I can take almost any situation and unless it goes absolutely perfectly, I can dissect it out and find areas in which I think that if I had this exact patient, this exact scenario again, how would I want to change our performance in that area to optimize it? It doesn't mean that finding a change means that something was done wrong or something was done below a standard. That's usually not the case, actually. It's usually just, if I had this opportunity again, here's what I would do. Here's what some of the literature says. Here's what some of the outside experience has been. Here's what some of our other colleagues have said, and let's look at it, and it benefits everybody.
We have a committee of the Trauma Advisory Council, the Quality Improvement Committee, and basically how that works is that the Trauma System Act has some language in there that says you need to have quality improvement activities, and they wisely put provisions in there that information that comes out in these committees is protected. It can't be used in any legal proceeding. You can't get the information from that committee from a Freedom of Information request. It's all protected. So when a situation comes up where we think that there needs to be a review of a case that maybe there were some problems with, we get the doctors in there, we get the nurses in there, we get pre-hospital people in the same room talking about these various cases in a manner where they can feel comfortable doing it. They know the information is not getting out, and it's also non-punitive. Nothing is bad going to happen to them.
When we first started having track meetings, I had the opportunity to be involved in PI in a very small way, but one of the things that I took away from that, and I think we're getting much better with it, is it was seen as you didn't want the PI committee getting your stuff. That meant trouble. That meant that there was going to be discipline possibly, and we want to steer away from that. The only way we're going to get better is to look at our mistakes, look at the things that look at that scene time. What took too long on that scene? Why did that patient stay in the ER for 2.5 hours before they were transferred out?
When I bring people in, whether it's a discussion or whether it's a meeting, I let them know, up front that it's not a punitive process and that we're just going to look at this, that if you had the same scenario next week or in 2 weeks, what would you do differently, knowing now that you have the information that you have? I think feedback is very valuable. If you don't let EMS know, if you don't let the physicians or nurses know the outcome and give them feedback, I think it's hard for them to change. But I think if you let them know up front, it's just because we care about the trauma patient, no one's perfect, that everyone learns something every day, and that we can always identify an opportunity for improvement.
We work with Five Rivers. Usually Paula will call us over and say, hey, this particular call, we're not coming in here, we're not dinging you for it, we're just explaining this is ways to improve on this specific call. And if there was an issue, then that's what we talk about ways to improve, how we could have done it better. Initially, when they started out with the PI, especially here at the hospital, we were, like I said, all a little bit afraid, scared, kind of what are we going into, a little bit nervous. And it really kind of turned into a joke, because I say a joke, we started saying, hey, you got called to the principal's office, because when you were in school and you went to the principal, you knew you were in trouble. But once we got over there and we started talking, basically all we were doing was sitting down, we're going over particular runs. Hey, could we have done something different? How could we improve this particular call? We're critiquing it.
I think the ability in our system to do system-wide performance improvement is also very unique. Most states don't have that ability, and I think we've been able to take real cases and put them on a table in front of the people involved in the rest of the system and looked at them not in a punitive way, but in a way that identifies opportunities for improvement and lets us create an action plan that makes sure that those opportunities are met and those mistakes, if mistakes were made, are not made in the future.
The Arkansas legislature included injury prevention as an important part of the trauma system. One example is through establishment of the statewide injury prevention program, a partnership with the Injury Prevention Center at Arkansas Children's Hospital, where subject matter experts provide technical assistance across the state. Another is the enhancement of ADH's Hometown Health Initiative resources so that there are grassroots and community-level interventions being conducted. Finally, creation of the Injury Community Planning Group brings state-level leadership in all aspects of injury prevention to the table to ensure coordination of efforts, plan core activities, and evaluate programs. A recent success of the above collaborative efforts involved the ADH's distribution of approximately 4,800 child passenger safety seats throughout the state and their installation by certified technicians.
You know, we have really done, I think, a very good job in the 5 years that we've been at this in implementing the trauma system. I can look at this thing now and say it's probably not completely built, but it is largely built. We have a lot of the things in place that need to be in place to say we have a functioning trauma system in the state, which is wonderful.
You know, I think in 5 years, what I think we would like to see is there not to be a question about where patients go. I know that if it were my family, that if my family had a major traumatic event, that there wasn't a question where they should go. The process had been vetted, it had been tested, that I know and I can feel confident knowing that regardless of where in this state someone is injured, that they make it to the right place within the period of time that's most important for the injuries that they have. To see hospitals and EMS providers working better synergistically together. I think 10, 15 years ago, it was an adversarial relationship. Pre-hospital providers and hospitals didn't get along. And I think now you're seeing them come together, and I think I'd like to see that improve over time.
I envision the trauma centers and the trauma system in 5 years to be improved even upon what they are now. Just looking back at the hospitals and their performance from even 5 years ago, there's been a tremendous amount of improvement, and I only see at this point that the system is going to get better. I do think that everyone needs to redouble their efforts as far as participation in the trauma center and participation in the re-verification process, and so that we're all on board.
Well, you've got everything in place. We're working hard to make sure the patients get the best treatment they can, get them to the right place, all those things. We now have to show that we're being successful with the system, and the key word there is data.
We've got such a great cohesive network of this and our data is good now, and I'm looking forward in the very near future that we can make good statements about what we do next. I also think we have the opportunity to set the bar nationally in a lot of areas based on what we're doing in Arkansas. And because we have, again, a very cohesive system, we have a data set that merges the pre-hospital to the hospital to outcomes, and we have a quality assurance group that's able to look at that, I think we are in a very good position to answer some of those important questions that have eluded the pre-hospital folks for decades.
I think we're good, but I don't want us to settle with good. I want us to get to great. I think the only way we can do that is by open communications from the ground to the air to TraumaComm to the hospitals. And not just open communication, but open minds to new ideas. Let's look at other systems that are doing things right and mimic that. And also, look at where our pitfalls are and be able to accept the problems through a systematic approach, fix those problems. And the best way to fix those is open communication.
Our leaders have done a great job in the state getting the trauma system to where it is. I see it staying in Arkansas. I think Arkansans care. I do. And I think it's just going to be up to us, each facility that has a drive for trauma to maintain it and for the system to continue.